place where when we get on with him, then, and he finishes, then I can finish up and we'll be out of here, okay? All right, so let's talk about the nursing process, which we already have, because we discussed all of this stuff about the coordination of care. We talked about who's involved, psychiatrists, psychologists, counselors, all of these people, who are involved in the care. Also, we need to also remember about teaching education, which is very important in health promotion, because now in a few minutes when we start talking about these different disorders and the medications, there are certain things about these medications patients may need to know. First of all, if you start, and I don't wanna jump the gun, but just one for an example is that if you start the medication, okay, you need to continue it, because a lot of these medications don't just start working in 2 or 3 days. We see that it may take up to 2 weeks before you start seeing an effect, okay? So that's part of teaching, health promotion of things they need to do as far as making sure they follow up with their doctors, make sure if there's medications that there are, that needs to be in a certain range, make sure you know the range and what you need to do about making sure these medications are in a certain range, all of those things. Pharmacological, biological, we're not gonna talk about, we've talked about all those therapies, we've talked about milieu till I'm blue in the face, and milieu is something that you should have circled on your paper, because you may see it again. Therapeutic relationship and counseling, which we've talked about that, okay? So let's go into actually talking about the disorders, okay? So the first disorder we're gonna talk about is anxiety. Have you ever heard that song, Anxiety? I can't even think of the singer's name.
Megan the Star, is it?
Yeah, so every time I think about that song, it makes me laugh, because I'm thinking, okay, I am really suffering from some anxiety right about now. Then I start singing that song in my head. But anyway, anxiety is subjective, okay, it's a subjective experience. And we know that occasional anxiety is expected. Signs and symptoms can range from mild to panic, okay? So when we talk about mild anxiety, we may have restlessness, we may have irritability, we may have nail biting. How many of you bite your nails? You can have finger tapping and fidgeting is mild. Moderate, our perceptual field narrows, and we have a diminished inability to fully focus. We may also see perspiration and start suffering from headaches and urge to urinate. And we can also have an increase in heart rate. Our respirations may also increase. And then we may also see tremors. During the severe stage, we can only focus on one small thing. We become dazed, and we can become confused. And we're not able to critically think. This is also at the stage that you could see some hyperventilation. You've seen some people have an anxiety attack that they begin to hyperventilate. We can also suffer from insomnia, start having pounding of the heart, and feeling like a sense of doom, like the world is about to come to an end, so to speak. At the panic stage, we can lose touch with reality, and we are so exhausted by that point. Then it could lead to harming ourselves, because again, in the severe stage where we see that sense of doom, if we go into the panic stage, we can get to the point that we feel like we can't go any longer. We also may experience or see people experience running, pacing, screaming, and some withdraw themselves. In the case that a person is going through an anxiety episode, panic episode, we want to make sure, of course, they're safe. We want to provide a calm environment, okay? They don't need to be in a panic stage and we go into a panic stage, because it's like a domino effect. They see we can feed off of each other. So we want to make sure it's very calm for them.
You gotta press it or else it's gonna shut down.
Oh, what?
It's a button on the computer or something.
It happens every day.
Does it?
It's just,
Oh, that could be that complicated. Thank you. Okay.
It'll
There
get
you go.
one more.
Okay.
Yeah, you're done.
Okay, all right. So what are some, we need to look at some coping strategies for people with these disorders, okay? How can we focus on the problem? That's something we need to do. Learn how to focus on the problem and how can we get a grip of the problem. So there we may have to have some type of counseling treatment. Things like yoga, spiritual exercise helps with that. So even with us, those are some things that we need to be doing just for our level of anxiety, or those things also, okay? Okay, so when we talk about anxiety disorders, generalized anxiety disorder is this first one that we're talking about. And it consists of panic disorder, which we just talked about. It also consists of phobias. Okay, so if I'm claustrophobic, that can cause me to go through some anxiety. What is claustrophobia? What's hydrophobia?
water.
Yes, so in your book, in the Saunders, it tells you different type of phobias, okay? So that falls under this. Separation anxiety disorder, that falls under anxiety disorder. What may that include? That may be like, for instance, a child going to school for the first time and being separated from their parents. So that first time, they can even experience what we call separation anxiety disorder. So there's different type of disorders in this whole realm of anxiety disorders, okay? But in order to be diagnosed with anxiety disorders, it has to be persistent over 6 months. So here it is that we're talking about. It can't just, I'm having anxiety, okay, I got a diagnosis of GAD. It has to be over a period of 6 months. And you have to have 3 of these symptoms. 3 of these symptoms. Restless, on edge, easily fatigued, sleep disturbance, irritability, muscle tension, speaking of that, difficulty concentrating. So again, looking at phobias, we talked about that fear of a certain thing. Okay? Phobias are a fear of a certain thing. Fear of height, what is that? Anybody know what the fear of height is? I forgot myself. But go in your book under, in your Sunday's book, and it tells you different type of phobias. Just be familiar with them, cause you can see them again on HESI or something, okay? So just be mindful of it, and know that it is an anxiety disorder, okay? Separation anxiety, we talked about, we usually see it in children. Reaction to being separated from parents. Also, obsessive compulsive disorder is an anxiety disorder. So when we talk about obsession, it has to do with thoughts that we can't control. It's things we can't control, but it consumes our brain with specific things. And then the compulsion part of it is that we feel like we've got to do something about it. So I am obsessed with my hands, hygiene of my hands being clean. That's an obsession. The compulsive part comes in is when I have to wash my hands 50 times a day to make sure my hands are clean. So that's what we call OCD, obsession. I'm obsessed about cleanliness of my hands. Compulsion part comes in when me having to wash my hands constantly, okay? Post-traumatic stress. This is triggered by experience. So again, if you had some post-traumatic, something real detrimental in your life to happen, it can come back when you think about that all the time, and it can cause flashbacks, can cause nightmares. So when we look at all of these different type of anxiety disorders, okay, these are some treatments that we have for them. There's different type of cognitive behavioral therapies that can be done. Exposure therapy is a therapy that can be done, especially for those who may have phobias. So say, for instance, if I have a phobia of snakes. So one way that I can get over that phobia is through, right, you're exactly right, that's how I would be. We would focus on that by first in a therapy session where maybe I may see a snake in a cage, okay? Once I get past that fear, then the next time somebody else may hold the snake.
Absolutely.
Okay, and once I get comfortable with that, then the next time I may hold the snake. Okay, that's getting over your phobia. So that's an example of exposure. EMDR, which is eye movement, desensitization and reprocessing, don't even worry about that. But it is something that is used with PTSD now, where it has something to do with the eye movement of helping you somehow get over PTSD, whatever that is that you're having those flashback with. I can't really explain it, but just know it's out there. TMS, which is transcranial magnetic stimulation. This is used for for OCD, where there is a certain type of magnet that is supposed to activate your brain, and it deals with that specific part of the brain that's causing that obsession. This is crazy stuff. Yes.
I worked at a place that had TMS, and I think you just mentioned it works for major
Yeah,
depressive.
I'm TNS certified, so
So what now?
I give those treatments.
What treatment?
TMS.
You do?
Mhm.
So what is it?
So you have to, mine was mainly for depression.
Yeah.
My patients had depression, so you have to go through so many medications that don't work.
Yes.
And then you have to do a PHQ-9 and it has to be so high, you get qualified. And then you come in and you get mapped, so pretty much you get it's like a hat kind of on you, it's a white hat in front of you. And then you which part is the strongest. And then every time you come to treatment, which is Monday through Friday, and the treatment is 27 minutes, so you have to put it directly on that same spot every time, because whatever it is shrinking that, so that it can get better over time. And every day you come in, you have to do a PHQ-9 score, and you do see it go down over time.
Wow, and so, okay, so it helps with OCD also?
My patients didn't have OCD, they were all major depressive.
Major depression.
Yeah, the place I worked at was also only major depressive, I never saw it for OCD.
Okay, and you come in every day, 30 to 60 minutes, 30 minutes or so?
Mine was 20, they were 27-minute sessions.
Okay, and it's no anesthesia, non-invasive stuff that you have to do, right? Okay.
You sit in a chair, they can talk English to you, they read a book, or whatever they want to do.
Wow. So you do know that this type of therapy is out there, but how do we like to start treating our patients?
Non-invasive.
Non-invasive and with medications, yes. So, with anxiety, okay, benzos are the medications that we look at. So benzodiazepines, these are some examples. Now, if it's used on your test, if you see medications on your test, it's gonna be the generic name. Because when you go and take, of course, your HESI and when you take your NCLEX, they use generic names. So you have to have an idea of how you're gonna remember these by the generic name, okay? It's easy to remember Xanax, but I need you to remember alprazolam, okay? So when we look at the benzos, we're looking at like alprazolam, clonazepam, lorazepam, the PAMs, okay, benzos, that's how you can remember that, and temazepam. The action of these medications is CNS depression. So some side effects can be sedation, hypotension, and respiratory depression. For its teaching, we want to make sure that we tell patients not to use heavy equipment and to avoid using alcohol. And also, do not stop taking these medications abruptly. Now, when we talk about benzos are used for short term. The reason for that is because they can become addicting. So when you look at medications like the alprazolam, which is Xanax, but alprazolam, usually those medications are ordered as needed, which kind of helps you get out of that little being anxious for a minute, but it's short-term medications. It shouldn't be something you should be on like every day. Also, a medication for anxiety is what we call buspirone. Its action is to increase serotonin and dopamine. Now, some effects of buspirone is that it can cause nausea, headaches, vivid dreams, dizziness, drowsiness. And it can also cause serotonin syndrome, which we'll talk about in a few minutes, what that is. So for its teaching patients, we want to teach them no grapefruit juice because it increased the levels of toxicity, risk for toxicity. Of course, no alcohol. And with this medication, it takes 3 to 4 weeks before you can see a difference in it. So you have your benzos, which are short term, then you have buspirone, which takes, longer term medication for anxiety. And then you have hydroxyzine, which is a medication that kicks in quickly and is not as addicting. And this medicine is used more for patients who cannot take benzos. So when we talk about anxiety, if it's something that we need for as a short term to kind of get us off the edge of anxiety, usually we'll give a benzo. Something that needs to be more long term, like something we need to be on at all times, that would be like buspirone. And also some antidepressants are used that we'll talk about in a few minutes, okay? And also, sometimes patients will be put on a beta blocker. Now, why would they be put on a beta blocker?
Because anxiety can cause a high heart rate.
Yes, exactly right. So sometimes they may be put on metoprolol, something like that, to help with their heart rate. So for us, the psychoeducation, these are some things, we're on the medications, we need to get a better sleep schedule, okay? So a lot of times when they are doing report on patients in psych, they're always telling them, well, the patient slept 4.2 hours. Because it's so important with all of these disorders that we get sleep. Okay, so we touched that. And also, this is a black box here that's saying that patients who are on benzos and opioids, it may result in profound sedation if you're on both of those. So it's very important to make sure that you have patients who are on both of these. We need to watch for that respiratory depression, okay? Because it is doing what? Depressing the central nervous system. So, for as nurses' roles, again with anxiety, we want to make sure that the environment is calm, okay? Make sure you listen for expressions of suicide. Here it is again. If they say it's overwhelming, I can't go on anymore, those are some signs of expressions of suicide. Let's talk about depression. Depression. This is actually talking about Robin Williams, who actually died from depression. Okay, and anybody know what he did? What was his occupation?
He was an actor.
He was an actor, comedian, and he had problems with depression. Yes. So when we look at depression, it can be a wide spectrum of mood disorders. We can go from mania with psychosis to severe depression with psychosis. We can have psychosis with things that are not schizophrenic. So we can have psychosis like delusions with depression, and we can have hallucinations. And did y'all know that depression is the major cause of disabilities? 25 to 35-year-olds, that you can see it across the lifespan, but it usually starts between 25 to 35. You can have it with other psychotic disorders. Now also depression we can see with bereavements, we can see with postpartum, we can see depression with those things too. And also a different type of depression, or type of depression, is seasonal affective disorders, where some people can become very depressed in the wintertime, and then their mood gets better in the spring or summer. So when we talk about how a person is diagnosed with depression. You must have 5 or more of these symptoms in a same 2-week period. So you've got to have a change in the mood. You've got to have mood change and loss of interest as 2 of your 5 symptoms, okay? So you've got to have mood and interest change. Then you've got to, then your other symptoms are eating. You can eat a lot or you cannot eat much at all. Sleep, that can be you want more sleep or you get less sleep. Your motor activity decreases, your fatigue, being fatigued is very high, it becomes increased, and your self-worth becomes decreased. And your concentration becomes really low. And then again, 5 or more symptoms must be present during the same 2-week period. And at least 1 symptom must be depressed mood or loss of interest or pleasure. So again, here we go with treatments. We're just repeating the same things over and over really, until we get to the different type of medications, which we're gonna concentrate on, okay? So when we talk about medications, well, let's go first to the suicide precaution, which I had mentioned to you earlier. When we have patients who are on who have depression, these are some things that even in the psych unit itself, these are some things that we're not gonna have because we don't want to commit suicide or anything. And again, going back to the patient care that I was talking about, we want frequent observation of them, and usually it's 1-to-1 where someone is strictly on them at all times if they have suicide ideations. And you see that a lot again, like I said, in the emergency room. So when we talk about antidepressants, we have different ones, okay? So we have SSRIs, which are serotonin selective reuptake inhibitors. And the action of these medications is to increase the serotonin. And this is one of the medications that can also be used for anxiety. So we actually could use these for depression or anxiety. So when we think about the examples, here we go, the ones that I want you to be familiar with, because I may use these drugs on the test, okay? The fluoxetine, which is Prozac, sertraline, Zoloft, and citalopram, which is Celexa. So fluoxetine, sertraline, and citalopram. And then we have the SNRIs. The action of these medications is to increase the serotonin and norepinephrine transmitters. And some examples of these are the duloxetine, which we know as Cymbalta, and then venlafaxine, which is, we know it's as Effexor. Then let's go back to the SSRIs. I jumped gun a little bit because some of the side effects is that it can cause GI upset, it can cause blood pressure changes, up or down, increased libido, and it can cause weight changes. Now, also these medications take 2 to 4 weeks to become effective. So what is something that you see that is common, look like in all of these medicines just about?
It take a few weeks for
It take a few weeks for it to work. So don't say that it's not doing anything, it's not working for me, and it's only been 4 days. It may not, okay? It takes about 2 to 4 weeks. So some teaching things for being on SSRIs: don't take a couple of doses and stop. Avoid alcohol, because that can increase the risk of serotonin syndrome, which again, we're gonna talk about in a few. And also, going back to the SNRIs that I just discussed about Cymbalta Effexor, they're practically the same as the SSRIs. So you're gonna practically see the effects, the teaching strategies, all those are the same as the SSRIs. Now the NDRIs, the norepinephrine and dopamine reuptake inhibitors, these increases the norepinephrine and dopamine. So you see these are used in depression and also for smoking cessation. These medications increase risk for seizures. And it's not recommended for you to be on this if you have an eating disorder, because this medication also decreases appetite. So if you got an eating disorder and you're already not eating, then you're on this. That's not good. And then you also want to caution with other stimulant use. So the big example of this type medication is the bupropion, which we know as a label name, Wellbutrin, okay? But you need to know bupropion. Okay, so let's talk about serotonin syndrome. These are the symptoms of serotonin syndrome. So you can get this with high doses of meds that affect the serotonin. So this is why it's also important to make sure that you know a patient's meds, what they're on, because if it's also messing with the serotonin and we're doing the same thing, it can cause the syndrome. So with this syndrome, you may see shivering, hyperflexia, hyperactive reflexes, increased temperature, your vital signs can be abnormal, encephalopathy, restless and sweating. So if you look at the word shivers, that'll kind of help you know or know what the syndrome is or the symptoms. So what do we want to do if we suspect a person is going through serotonin syndrome? We want to stop the medication that is given, that's increasing the serotonin, and then provide supportive measures to stabilize the vital signs, and we may want to give some IV fluids if we need to. TCAs, the action of these are to increase serotonin and increase norepinephrine. The biggest things that we can see as a problem with this, it is you at increased risk for lethal dysrhythmias. It can cause dry mouth, blurred vision, and urinary retention. And these type meds are effective in 2 to 6 weeks. So some examples of this is amitriptyline and nortriptyline. the MAOIs. Now these medications, phenelzine, trazodone, and isocarboxacid. Now these medications are medications that would not be a front line of choice. Because what happens with these medications is that these medications can cause a hypertensive crisis because of tyramine. Because foods that have tyrosine in them turns into tyramine. And this is what can cause the hypertensive crisis. So foods that's high in tyrosine can be raisins, milk, yogurt, beer, wine, chocolates, all those good things, right? Things that we would really want. If we're on those medications, it's not good. And these medications are not used as much because of this issue. Okay, so again with antidepressants, and after we look at this one, then we're gonna pause for our Zoom in. So out of all of these things, what I want you to remember here is that we do not abruptly stop the meds again, because it can make you feel so bad when you stop these medications. Again, it can cause serotonin syndrome. So again, be familiar with those symptoms. And again, for his education, make sure you educate the patient to give the medications a try, which means continue to take the medications. Again, it may be 2 to 4 weeks before you see a difference. So right now, I'll say maybe 5 minutes, it's 5:50. I'm gonna go ahead and put it on Zoom and we're gonna get started at 6, okay? So y'all get up, stretch,